I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti. I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
39-year-old young female, never smoker, with a T4N3 of the left lung, big tumor, 7 centimeters by 6 centimeters by 3 centimeters, with contralateral nodal disease. So a stage 3B lung cancer. The tissue, unfortunately, is insufficient for moleculars, and we can make a point here. Do we need moleculars for a young patient with stage 3B disease? So in this case, Dr. Govindan, would you want to get tissue again? Would you order a liquid biopsy, given that she's a young lady, never smoker, and would you use that information for this type of patient?
You know, doing a liquid biopsy or cell-free DNA, to be more precise, is not unreasonable. But you have to keep in mind that there is a fairly high incidence of false negative results in the setting of predominantly thoracic confined disease. So if you find known activating mutations that are well known in lung cancer and cell-free DNA, absolutely, that's within 7 to 10 days you can get the results. Maybe that's a good place to start off. But an important point is that if you don't find an actionable mutation in the cell-free DNA analysis, I would absolutely go and get a repeat biopsy. And if necessary, I would even convince our thoracic surgeons to see whether we can even do a more invasive procedure to get a biopsy. Because it is precisely in this population, I mean, she has 3 things going for her: age, sex, and the smoking status. All 3 would point to an extraordinarily high prevalence of an actionable mutation. In this instance, ALK, for example, is a high likelihood given the age in that age. That said, this is only relevant, in my view, if definitive chemoradiation cannot be done. This is a constant problem that actually baffles practicing physicians. If you have a 39-year-old never smoker has ALK positive disease, if this is amenable for definitive radiation treatment, the best treatment for these patients is concurrent chemoradiation. And then, of course, you can argue about the role of durvalumab, and I do that currently. There is no role that targeted therapies are useful in this setting in lieu of chemoradiation. So I think people should not lose sight of that. And the targeted therapies do not cure cancers, they only control the disease. If you can cure cancer through definitive chemoradiation, I would go for it.
Great. And Dr. Kieran, just briefly approach on a very large tumor in a young female. Any particular considerations for this patient given the size of the tumor? Again, we don't have the images. How you talk to patients about radiation in these cases?
Well, yeah, I don't feel good about this patient in terms of long-term outcome. I'm sure it's technically possible to treat her, but it's going to be a tough road. She's fit enough to receive aggressive chemoradiation. The question really is there benefit? But certainly like to know some of the biology of the tumor in such an unusual case to see whether we can add targeted therapy earlier than later.
Would you favor, Dr. Kieran, and again, we don't have a lot of great data on genotype-directed therapies in stage 3A or 3B. Would you be okay if someone wanted to start with targeted therapy and then if the patient did have a target? Would you be okay with that approach? We can talk to Dr. Govindan whether he would do this, but is this something that would be advantageous to your radiation planning?
I think let's say she had a EGFR mutation that was amenable to osimertinib. The idea of giving that for several months see whether there's a response, I'd be open to that. We have some pilot data suggesting that certainly the outcome is no worse in stage 3 disease, and in some cases better. So in an unstudied environment with a really bulky tumor, I'd certainly be open to that.
In the absence of a genetic alteration, would you give her the benefit of the doubt and do definitive radiation with chemotherapy for this patient? Or are you still concerned that she needs some sort of induction?
No, I'd go without a mutation. That's the way I would go. You know, what if she had a very high PD-L1 status? Would we think about pembro for a while? I don't know. Not a crazy idea.
Okay. 2 more questions, and we'll move to the last one. Dr. Govindan, one, would you consider using, I mean, this is always the question we get in some of these meetings about, would you consider using a TKI if she had a genetic alteration? That's number 1. And 2 is, and this is just for this case here, if atezolizumab is the only immunotherapy option available at the facility where this patient is being treated, and the patient does undergo definitive concurrent chemoradiation, would you be okay using atezo rather than durva as consolidation?
So the first question is that if there is a targetable alteration, such a large lesion, if you want to significantly have cytoreduction, I think it's not unreasonable to do it. Also, we see the greatest cytoreduction in the first 6 weeks to 2 months. So I think if radiation is certainly in the cards, I would rather do it sooner than later. I definitely would be open to giving induction therapy with a appropriate targeted agent for 3 months, and then consider a chemoradiation, which is would be not unreasonable if radiation is deemed appropriate. In terms of atezolizumab, it raises 2 issues. One is atezolizumab, or these checkpoint inhibitors are all the same? The answer is not so clear. And what we have tested is durvalumab. It's certainly not unreasonable to consider that's the only thing available. But also the other question is that, do never smokers benefit? Do smokers with EGFR mutation benefit from these targeted agents? We don't have, I mean, with checkpoint blockade after chemoradiation, there's not much evidence to say they do. The limited data suggests that they may not, but the studies have included them. So I would give this patient atezolizumab with all the caveats, given the fact that we are in a difficult situation. A person so young technically has many years of life expectancy. I would do everything I can to help. I would give atezolizumab, yes.
Okay.